Our next speaker today is Dr. Samir Taneja from NYU, talking about concepts in focal therapy margin assessment.
So I think Art just said everything I do is wrong.
It wasn't your paper, though.
No, I'm talking about the way I plan focal therapy, but we'll see. I didn't realize my talk is 10 minutes, so I'm going to try to go through it quickly and share with you what I think are important issues related to margin planning in the implementation of focal therapy. So this has been of great interest to me for a while. I think successful focal therapy relies on adequacy of the primary ablation, and that's why I was asking the questions earlier about invisible disease. A lot of what we treat in focal therapy we don't necessarily see, but we estimate the extent of the tumor. So I was going to talk to you today about some of the tools we're using to try to improve our ability to assess tumor burden. So if you think about the goal of partial gland ablation or focal ablation, it's obviously adequate locoregional disease eradication, and many may define that in different ways, but it translates into destruction of known disease and most likely some degree of unknown disease. We also do this to mitigate the risk of metastatic potential. So as has been pointed out this morning, it's not the conventional Halstedian wide margin eradication of all disease, it's mitigation of risk that occurs through local regional control and avoiding radical intervention. So I won't talk much about this, but for those of you who are new to the focal therapy field, the root of this idea comes from a paper that was published over a decade ago that suggested that all metastasis in prostate cancer patients who died of disease had origins in one clonal phenotype or genotype in the prostate. Now that's been challenged, but that sort of sits at the root, that if you can find the index lesion and destroy it, you remove the ability of the disease to metastasize. Obviously, a number of controversies remain. How do we define that index lesion? I think the overwhelming evidence now is that MRI is probably the best tool for us to identify the index lesion, though it may be that molecular imaging will add to that. And then the other question is, what is the true significance of the disease we left behind? Yesterday, someone referred to this paper showing that, this was Rob Reiter's paper, that in radical prostatectomy, 39% of high-grade tumors were missed by the MRI on whole mount evaluation. But of course, what you have to realize gets back to the question we'll talk about. Where are those small high-grade foci? Are they within the halo of the dominant index lesion? And that wasn't really discussed in this paper. And how clinically significant are they simply because they're Gleason 7? The other controversy, of course, is how much is too much? How much do we need to treat? And I think this will be an interesting question going forward. Is the morbidity of a hemiablation, for example, different than the morbidity of a simple focal ablation of a small lesion? Is the morbidity of a subtotal ablation worse? Early studies have suggested there's not much functional difference, but I think that depends on the energy source and probably to some extent the operator and the patient population. So I think it's something that's not been studied well. As of yet, my bias is still to tailor the ablation rather than to arbitrarily perform a hemi or subtotal ablation in everybody. Do we need to destroy the whole tumor? Well, I think so. There's a consequence of inadequate ablation, and that is that the tumor will inevitably grow back at the margin, and we'll see margin failure. I think early failure rates are typically due to that, and I'm currently overseeing a clinical trial called the VAPOR-2 study. We designed that study to allow for retreatment, but we still designed the intervention to try to maximize the chance of complete tumor destruction at the first go. There are several reasons people fail, or focal therapy fails rather. One is incomplete ablation. The other would be progression of multifocality, so growth of some of these secondary or tertiary lesions, and of course de novo tumor development in the long term. I threw up an old abstract that we published a while ago or presented a while ago at the AUA, and notice the lines with the arrow. The men that I've had to re-ablate, typically it's early, and it's most often due to margin failure. Those that we've converted to radical treatment, it's much further out, and I think that reflects a different biology. I think that's this de novo tumor development or somebody's multifocality blossoming. So years ago, we did a study with one of the residents from Arnold Villar's program who spent a year with me, where we developed a methodology. If you've heard me speak, you've seen these slides before, but it's basically the idea of comparing what we see in the MRI to what we see on whole mount histology. And we utilized a methodology called Hausdorff distances, where we measured the histologic boundary in comparison to the MRI and measured the distances between the two margins to assess how wide an ablation we would need to do to adequately destroy lesions. What we found was that almost reliably, as has been mentioned many times today, the MRI underestimates the extent of the disease. And if you just target that area and leave behind the invisible disease around it, you'll have a margin recurrence typically. We found that the margin that was optimized in all the cases was 9 millimeters. So we've employed a 10 millimeter margin strategy since we published that paper. I think this is supported by other people. This is Wayne Brisbane's paper, which suggests that the majority of clinically significant cancer is within 10 millimeters of the ROI. Interestingly, one of the things that doesn't get talked about in this paper, though, is that penumbra distance varies considerably based on the PIRAD score or the Likert score of the MRI lesion. And that makes sense. Higher suspicion disease probably has less of a halo than lower suspicion disease. Similarly, high-grade disease may have less of a halo and be more likely to be well demonstrated on the MRI. So we've used a strategy of MRI-targeted biopsy, perilesional biopsies that are positive are then incorporated into the margin assessment. I try to create a 10 millimeter intraprostatic margin, typically a 3 millimeter extraprostatic margin, and that's how we've conducted ablation for the last now 12 years in my program. Here you can see a biopsy map, which shows a case with a lesion posteriorly. The target lesions are positive, the systematics are all negative. So this is an optimized sort of case for focal therapy. So what I go through in my process, I don't have all the fancy expensive tools that Northwell buys art. So I just look at the MRI and I scroll through the image from base to apex. I want to know the basal extent of the tumor. And here, this tumor, interestingly, is best seen on the DCE sequence in the bottom. Then I will line up the lesion and look at its relationship to the base and the apex so that I want to know extent. And then I measure the distances myself to incorporate a 10 millimeter radial margin, a 10 millimeter basal, and apical margin. What you see is in most glands, it becomes a partial hemiablation or a hemiablation because most men we're treating don't have 200 cc glands. And then we incorporate that margin measurement into our planning of, in this case, HIFU. Why do people fail? Well, it can be because of a non-confluent effect in the treatment zone, but on the right you see more commonly that if you misplace your treatment, you misalign it, you may find that you miss the edge of the tumor. And this is an example of that. A patient I treated with HIFU for an apical tumor on the left, and you can see on the right in the bottom panel, there's a subtle DCE abnormality along the ablation cavity, and the patient had residual disease and required retreatment. I'm not a big believer that fusion alone is a great way to guide focal therapy because there's so much gland distortion movement. So you really have to understand the imaging well yourself for intraoperative guidance. And the other things you have to think about are the effect of the thermal energy. Cryo in particular has a thermal gradient, and that's a source of margin failure. Similarly, there's a thermal sink if you have a warming catheter or if you have the bladder full of warm urine. These are places where you can achieve or you can suffer from margin failure. Two last things I wanted to talk about, I'm running out of time, I'll try to race through it. One of the tools we've piloted recently is an AI platform called Unfold AI, which emerged from Lenny Marx's program at UCLA. The idea is you take the biopsy pathology, the MRI, you put it into a machine learning model, and it predicts a 3D AI margin. So this is an example of a biopsy-informed Unfold AI margin, and then correlation with whole mount pathology. This is an example of a case in which the MRI prediction, although in this image I would question the MRI a little bit, the MRI prediction is a little bit off, and if you use the green dotted 10 millimeter margin, theoretically you may have missed some of the extent of the tumor. They've shown that at least, this didn't show well, but it didn't transmit well, but basically when you use this approach, the negative margin rate with a 10 millimeter margin in their whole mount studies was about 80%, hemigland margin was about 2/3, and default AI margin was about 90. So potential to improve margins. This is an example of a case in which I fused the Unfold AI prediction to a sonoblate focal therapy. And what you can see is I don't know if you can make it out, but the red dotted line is the 10 millimeter margin. The pink line is the Unfold AI. So you can see that they're not totally overlapping in each plane. And when I treated, I did my best to conform to both margins to maximize margin. Now, whether that's too much of a margin, time will tell. Last thing I'll show you is that we've been working on intraoperative mapping during our focal ablations. One of my fellows, Miles Manis, who's currently on faculty at UBC with Marty Gleave, Miles created a platform where we utilized an existing technology that uses stimulated Raman histology. So it's Raman spectroscopy at 2 frequencies that then converts to a histologic image. And what we did is we built a platform that allowed us to do this with prostate biopsy cores. We took fresh cores ex vivo in the OR, and we showed that with considerable accuracy, pathologists could read the SRH as well as they could read histology. We then built an AI platform that could read yes/no cancer in the core with about a 90% accuracy, 96% accuracy within 2 minutes. So what we've done most recently is tried to use this intraoperatively. So we take a biopsy, we then ablate, we take biopsies along the ablation margin, and if one of them shows cancer, as in this case, we then extend the margin with an additional freezing needle until we're clean. Using that approach, we showed that we had 2 of 23 patients, we found cancer along the margin at the first go, and when we expanded the ICE, we converted to negative. Obviously, it's subject to sampling error, but it's a novel concept. So in conclusion, I believe that in focal therapy, you have to believe in the index lesion theory, obviously, but I think defining the index lesion is still a challenge, something we can do better, perhaps with enhanced imaging and modeling strategies. I think full treatment of the index lesion is essential, and there are a number of different ways we're trying to do that. And I think an interesting question for future trial design will be how large does an ablation really need to be, and does expansion of ablation really influence functional outcomes after the treatment? Thanks, and sorry I went over.
No, please have a seat. Eris is going to talk, and then we'll do Q&A.